Now we are going to invite Dr. Jeffrey Robens to understand the clinical practice guidelines.
Good morning again. Nice to see you all again in a quite short time. So this lecture that I'm going to go through now is somewhat of an extension of the one I gave earlier. And when I was thinking about clinical practice guidelines, of course, as a publisher, we think in terms of clinical practice guidelines in reporting research. Because one of the big problems that could again lead to an important gap between available evidence and clinical practice is the reliability, reproducibility of what is known. Just because you can find that evidence, how well that evidence can actually be used may also be an important aspect leading to a gap between evidence and practice. So you do need to transparently report all of the research that you do in a way that it has international standards, that is respected, reliable, and importantly, reproducible. There's a number of papers and articles and news releases that have been released related to the problems with reproducibility in clinical research. Now people are calling that we need to have better validation, more reproducibility. In that way, clinicians can rely and believe and trust the evidence that they see. But that's easier said than done. And because of that, there's been a number of reports demonstrating that a lot of clinical research is not dependable. It is not useful. And that is problematic. Not only is it research waste, all that valuable time, money, exposing patients to potential harms, but it's also going to make it more challenging for you as a clinician to whether or not you can believe what you read. And in many of these cases, they can be RCTs published in the top journals. So there are problems that you are facing, and not only in the discoverability of that research, but the believability in that research. So we at Nature conducted our own survey to truly try to understand, do researchers across various disciplines believe there is a reproducibility crisis? Or is this simply something that media has really blown out of proportion? So we asked 1,500 researchers in a variety of disciplines worldwide if they felt that science currently has a reproducibility crisis. 52% of those researchers said yes. They do worry that the research that is published, that they read, is not reliable. That is problematic. 70% of them have admitted that they are unable to reproduce the results of others. And in fact, 50% said they were unable to reproduce their own results when they tried to do so in the future. Now, generally, physicists, chemists, people from a very hard science background felt that their research in their field was a lot more reliable, probably because there is a lot less variability in those findings. But as you move to life science and clinical research, the trust in the research became less. The key culprits that led to this reproducibility crisis was selective reporting. As we talked about earlier, that positive results generally will be published much more frequently than negative results. There's pressure to publish from administrations, institutions, or hospitals. Because of this pressure, for example, there's been a number of reports from clinicians worldwide who have gone to start to fabricate the peer review process. Particularly from China, this has been a big problem. Just a couple of months ago, 107 papers from one journal, Tumor Biology, were retracted because of fabricated peer review from China. There's been over 500 retractions in PubMed in the last 5 years because of fabricated peer review. That means you need to be careful about what you read. Has it really gone through the real vetting process to ensure those results are reliable and useful? And about a third of the respondents have said they have started to take internal measures to ensure reproducibility before publishing their research. Now that's a good start, but it's quite sad. That means 2/3 of respondents do not. So this is going to be another problem that would lead a gap between available evidence and implementation to clinical practice. So there's a paper published in JAMA where they wanted to evaluate RCTs that had been published before and then have been reproduced and published. And they found 37 such RCTs that they wanted to evaluate the findings and conclusions. They found in this analysis that only 5 were reanalyzed by an independent group. The other 32 were done by the same group, who of course will be biased. So there's not a lot of reproducibility happening in clinical research. Why? Well, most people know that journal editors are not interested in publishing non-original findings. So because of that and the pressure to publish that many researchers have, they will not bother trying to reproduce what people have already done. But that is a shame because reproducibility is, of course, important. So we as publishers need to better respect and understand the importance of reproducible research, and researchers themselves need to understand the importance it is for them to reproduce, particularly maybe what was done in Italy. How reproducible is it with an Egyptian population? Of those RCTs that were reproduced, only 2/3 could replicate the findings and come to a similar conclusion. About 1/3 of those RCTs could not come to the same conclusion. Now that's actually not too bad if 50% of a lot of research is thought to be not that reliable. Well, for RCTs, which have a much higher standard of control and reproducibility, luckily we are able to see a better reproducible index. However, that does mean that about 1/3 of RCTs you may read, you cannot really rely on how trustworthy they are, should you be able to believe in them and to implement them into clinical practice. Now, the problem is not just fraud. I mentioned the case about fraud with a fabricated peer review, where people are falsifying reviewer reports or falsifying data. A lot of it is about people not being transparent in discussing what they've done. The robustness of the study is poor. It is not reproducible, or important evidence is not reported in those studies either. And in fact, this was the subject of another evaluation where they wanted to evaluate in anesthesiology about the reproducibility of published studies. And the conclusion from this was that non-reproducibility in scientific studies can be attributed to flawed research designs, improper statistical analyses, or scientific misconduct. But what I really want to emphasize is the flawed scientific design and statistical analyses, because these are things you should be able to overcome as long as you plan your studies carefully, consult with a statistician to ensure you're properly analyzing your results. So one way to do this is to use standardized reporting guidelines. Now, we at Nature realized we had a big problem. Because Nature is a very high impact factor journal with an impact factor over 40, we often publish cutting edge type of research, but that's the research that has a tendency to have difficulty in being reproduced. So back in 2013, we have abolished all the space restrictions on the method section to give researchers the opportunity to explain in as much detail how the research was conducted to improve reproducibility. And then last year, we've also established new standards for all life science preclinical type of research to ensure that there are guidelines that all researchers are following. And these guidelines are published with the actual papers in Nature and Nature-associated journals. Well, they're covering aspects related to experimental design, statistics, software, all materials and reagents, and especially how to obtain those if you want to replicate those findings, and how animals or humans were used in the study. So we're trying to establish international standards across our portfolio of journals to help improve the reproducibility of research. Now, this, of course, is not new. The Equator Network has been doing this for a long time. If you're not familiar with the Equator Network, you should be. This is an excellent resource, freely accessible online. Free is always good. Where they have a number of reporting guidelines depending on your study design of what is expected of you from the international community. For example, if you're going to publish an RCT, they have the consort checklist. For observational studies, the strobe checklist. For systematic reviews, the PRISMA checklist. And for case reports, the CARE checklist. These are useful for you to when you're trying to design your study. What are the international standards that are expected of you? These will be useful for you when you're writing your paper to ensure you're transparently describing exactly how the study was done. These will also be useful for you to help overcome potential regional biases that journal editors will have. I often hear many complaints from Egyptian researchers telling me that international journal editors are biased against Egyptian researchers or researchers in other emerging markets. I like to think that bias, which is probably true, has nothing to do with the country itself. It's the worry that you're not familiar with the international standards. If they receive an RCT from Cambridge, they'll feel much more confident that those researchers know what are these international standards. But when they receive a RCT from another university in a developing market, that's their concern. Is it robust? Did they have evaluable resources? Was it sufficiently powered? Was there sampling bias, etc.? So to show journal editors you are familiar with the international standards and you have in fact transparently described them in your paper, you can submit these checklists with your manuscripts. So if you're not familiar with the Equator Network, please do so. And in fact, more and more journals are starting to implement these Equator guidelines into submissions for their journal. For example, for Anesthesia and Analgesia has now, as of last year, incorporated the recommendations of the Equator Network into its new author for instructions for authors. As advocated by the Equator Network, Anesthesia and Analgesia now requires adherence to the applicable statements and guidelines and checklists for all submitted related manuscripts. Means if you submit to this journal, you will be expected to include the Equator checklist relevant for your study design. And you'll likely see this more and more. And I like to further go on to state that this is not a pedantic exercise. They really believe in what these guidelines stand for. They say, to the contrary, we believe that adhering to the applicable statement and guide and checklist will promote consistent study design, robustness, reproducibility, and transparency in the actual manuscripts that they publish. So this is important. We as publishers do understand that there needs to be standardization. So research being conducted in Egypt can be compared directly with research being conducted in the UK or elsewhere in the world. These guidelines help to set these international standards. So what type of important aspects should you be concerned about, either when you're conducting your research or when you're evaluating the research? As we mentioned, you may have to be careful. Whenever you read something that's published, does not mean it's true. It does not mean it is reliable. You need to act as your own peer reviewer. You need to evaluate various biases to determine how reliable are those results and should they play into consideration when implementing a certain intervention in practice. So for reporting about patients, for example, it needs to be stated clearly how those patients were enrolled, specifically the number. What we worry about, we talked about statistical issues. Many RCTs worldwide suffered from being underpowered. And so you need to do a power calculation. If it is underpowered, that means there's an increased likelihood of false negatives. And although there may be a difference between groups, you will not see it. And that could be problematic, further contributing to the gap between evidence and practice. You need to emphasize about inclusion and exclusion criteria. How are those particular participants chosen? Or when you're evaluating a study, look at that inclusion and exclusion criteria. Do you agree with it? Or are you worried about potential bias in terms of the reliability of those results? Also look at the sampling methods. Are they in fact appropriate? And do they use probability sampling and proper randomization methods? Again, meaning you can rely and believe in what you read. And lastly, are they using an intent to treat or on protocol analyses on all the data that they evaluate? This will all be important information, should be clearly described in the methodology sections of all papers that you read, and make sure you, when you're writing your papers, do so as well. You also need to be, of course, familiar with the Declaration of Helsinki that states how patients should be treated in all clinical studies. Core principles being human research should only be done when the successful animal studies suggest that this intervention may in fact be useful. That all protocols should be evaluated by an institutional review board before you actually begin the studies. That research should be conducted, of course, by qualified researchers who are trained on how to actually administer the interventions or collect the measurements during the study. The benefits to the participants should always outweigh the harms that they may be exposed to. And that because of that, all participants need to give their informed consent. And by informed consent, we mean that they are clearly aware of the objectives of this study, that they clearly understand the methodology that you'll be using, the risks and the benefits that they may be exposed to, that all their information will in fact be confidential, that this is, of course, voluntarily participation. They're not being forced, coerced, or being bought. In other words, you're not giving a financial compensation that's too high for their actual recruitment, and the availability of alternative treatments. So this is not the only one, again leading to voluntary participation. And most journals will expect you to use informed consent forms. WHO has an excellent one that's freely available. Different journals will have their own informed consent forms that they expect you to use. For example, those from BMJ. So you do need to be familiar with how journal editors expect you to discuss informed consent of your participants, but make sure the participants thoroughly understand what they're getting involved in. Another important aspect in reproducibility is how the data is actually reported. So for example, unclear data. If it's a histological analysis looking at where the staining was blue, well, what happened with the light blue colored cells? Were those considered positive or negative? What was the threshold? What about uninterpreted data? If they're looking at glucose levels, but then it was found out participants did not fast overnight, what happened to that data? How was it accounted for? Or related to missing data, what did you do with this missing data? Why is it missing? And how did you actually try to impute those missing information? Work with a statistician. There's a variety of sensitivity analyses, multiple imputation methods you can use to help you fill in the gaps in this missing data. But it needs to be transparently reported exactly how it was done. And of course, another problem is not in terms of the missing data, but it is related to negative data. Now, I'm not talking about negative studies. I'm talking where you do a study, where you maybe do a variety of analyses with a number of outcomes. Some of the outcomes are positive, some are negative. Just because it's negative does not mean they should not be reported. They should be. They are valuable. For example, it will be important for people to thoroughly evaluate the validity of the study by understanding all of the data that was obtained. It will be important to help generate new hypotheses. Why didn't this work? What are other ways we can approach this question? It helps prevent research waste, so people will not waste their time, money, and expose patients to potential risks when it's not necessary. And because many funding agencies rely on published data, it helps ensure that all the funding that they give is in fact not wasted. It is being given to those researchers who have relevant and important studies. And lastly, I'd like to talk about clinical trial registration. This is absolutely essential when you're doing randomized controlled trials. So clinical trial registration has been stated by the Declaration of Helsinki. Every clinical trial must be registered in a publicly accessible database. The World Health Organization has gone on to say the registration of all interventional trials is a scientific, ethical, and moral responsibility. And the International Committee of Medical Journal Editors, whose guidelines most international journals will use, states the ICMJE member journals require registration in a public trials registry. So if you are going to conduct an RCT, make sure you do in fact register. And this is true for phase 1 through phase 4 trials. Where should they be registered? Well, there are a number of WHO-approved registries. The most popular international ones are clinicaltrials.gov and ISR-CTN. Now, these are interventional studies. That means observational studies do not need to be registered, but you certainly can if you'd like. Retrospective registration can be done in some cases, but keep in mind many journals will not accept that. But regardless, most established, reputable medical journals will require registration before considering any RCT for publication. And now this is, of course, another problem. So in this study for the BMJ, they wanted to evaluate how many of these clinical trials actually go on to publication, similar to what I found looking at the anesthesiology RCTs in clinicaltrials.gov. They found of 632 trials completed by 2008, only 46 were ever published and available online. Again, about the 50% threshold we often see. Now, there's a great website I would like to introduce, freely available, called Trials Tracker. When you go to Trials Tracker, it will give you an idea of all completed trials in clinicaltrials.gov and how many of them have actually gone on to publication in PubMed. Here's an example of results I obtained freshly this morning to be as up to date as possible, where again you can see currently 45% of trials that have been completed have not been published. Now, what's useful about this website, you can actually evaluate universities as well. So this is looking, for example, at Mansoura University. They find in Mansoura University 74.6% of trials that have been completed in clinicaltrials.gov have not been published. So this is a way in terms of auditing and trying to determine how well your university is publishing what they actually do. This is a nice free resource you can use. And you want, of course, to ensure your hospitals, your universities are trying to cross this 50% threshold that is at least the international norm. So recommendations for improving reproducibility in research, which can help close the gap between evidence and clinical practice. is, of course, to identify an important and relevant research question that has clinical utility for the community. You need to be well read. What is important? Not only discussing with other clinicians, discussing with patients about relevant outcomes that may be important to consider. Also, you want to develop a robust study design. Work closely with a statistician, methodological experts, to ensure you are indeed following the international standards, allowing you to be able to get your research published in reputable journals and ensuring your findings are in fact reliable and reproducible. Always register RCTs before you enroll the first participant in the study. Clinicaltrials.gov is the most common, popular one, but of course others are available as well. Keep in mind, people are tracking the publication of these RCTs. More and more, this is becoming an important issue, particularly in UK, US, and many other regions. You'll likely see similar audits for publication of completed RCTs in Egypt and the Middle East in the near future. And of course, always try to adhere to reporting guidelines to ensure that your research is at the level of international standards, not only increasing the likelihood you will publish in the reputable international journals, improving your recognition and that of your hospital, but also improving the reliability and reproducibility of your findings. And of course, importantly, you need to publish both positive and negative results. Negative results are difficult to publish as more and more medical journals start to adopt alternative submission strategies, such as the registered reports. This will help improve the publication rate of negative results. You may also want to consider journals that do not evaluate impact or novelty, such as mega journals like PLOS ONE or Scientific Reports or Medicine from Walter Kluwer's. They only want to ensure you have a valid study design and it was done well. Doesn't matter to them if the results are positive or negative, they'd still be willing to publish your research. And so by adhering to this, you can then proactively try to help close the gap between the available evidence and implementation for clinical practice. So with that, again, I would like to thank you for your valuable time this morning.
Thank you, Professor Robin.